Welcome back to this segment of the module on this focus on adolescence, where we take a look at practical applications of some of the concepts that we had discussed earlier about the ideal elements of healthcare services for adolescents. Our program partners with homeless shelters, drop-in centers, transitional living programs, and other youth-serving agencies across the Valley to serve homeless and runaway adolescents, as well as young people who are at risk for homelessness and up to age 24 years. And we deliver a comprehensive array of services in a manner that I feel truly reflects the 7 essential criteria described by the American Academy of Pediatrics and by the Society for Adolescent Health and Medicine. Let's take a look at this particular case of JP. JP is a 17-year-old male who presented to our Thursday evening clinic at our community partner site 1 in 10. He had learned about our program and our services through a friend who had previously utilized our services and who accompanied him to this visit. He came in specifically requesting for screening for sexually transmitted infections, as he had recently initiated sexual activity. Our registration staff verified his insurance and saw that he was uninsured, but we were able to serve him anyway. He denied any symptoms of sexually transmitted infections, such as dysuria or urethral discharge, but wanted to make sure that he was, as in his words, clean. He self-identified as gay and had been in sexual relationships with 2 lifetime male partners. He reports having engaged in both insertive and receptive anal intercourse with inconsistent condom use, as well as having received and performed oral sex. He reports not ever having been previously tested for sexually transmitted infections. He also indicated being out to his mother and his 2 siblings, but came to our program because he felt uncomfortable discussing getting tested with his regular physician and discussing this with his mother. During his visit, we discussed minor consent statutes and assured him that he was able to access confidential services as a teenager through our program, and talked to him about his entitlements as a teenager to access confidential services as far as it relates to his sexual and reproductive health. His past medical history was otherwise unremarkable. During his visit, we reviewed his psychosocial history after first discussing with him the limits of confidentiality. JP was a senior in high school and he was making mostly A's and B's, and he wanted to eventually pursue a degree in music. He reported having a positive self-image and having good relationships with his peers. There were no concerns related to experimentation, use or abuse of cigarettes, alcohol, or substances, and he reported being in good emotional health. His physical examination was unremarkable. In our program, all patients who come in are screened for depression using a PHQ-9 standard screening tool, and his screening test proved to be negative. During his visit, we commended him for his decision to get tested, especially because half of sexually transmitted infections are asymptomatic and would not otherwise be detected if they were not tested or screened for. We assessed his motivation to engage in consistent condom use and safer sex practices, with JP acknowledging a desire to make better decisions and identifying poor planning as the reason for his inconsistent condom use in the past. During his visit, we discussed current screening recommendations from the Centers for Disease Control as they relate to males who have sex with males. And during his visit, we obtained screening tests for pharyngeal gonorrhea, for rectal gonorrhea and chlamydia, for urethral gonorrhea and chlamydia, as well as screening tests for HIV and syphilis. We provided him with a follow-up appointment in 1 week and verified his contact information so that we had a way to reach him if we needed to contact him. Let's break this case down. First, on measures of availability of age-appropriate services and healthcare providers with training, expertise, and experience in caring for adolescents, our program is staffed by adolescent medicine specialists and other pediatricians who have extensive experience in working with adolescents and a passion for caring for the population. We take advantage of regular trainings and extend these opportunities to our program nurses, our medical assistants, our front office support staff, so that we truly create a culture that welcomes young people. On measures of affordability, JP was able to see us despite his lack of insurance and his mother not being involved in his decision to seek screening for sexually transmitted infections because we serve all youth regardless of their insurance status and their ability to pay. We are very fortunate to have the support of the Phoenix Children's Hospital, of the Children's Health Fund, as well as various private foundations to make this service possible. In fact, in our program, we also have financial advocates on our team to actually help youth identify what health insurance plans they might be eligible for, and we help them connect with these insurance options and complete applications. We feel that it's critically important for us to do this because otherwise, they are just as likely to remain medically disconnected from healthcare services as when they first access our services. On measures of confidentiality, JP came to us with this request because he knew that his request would remain confidential. The commitment to delivering confidential care is something that we take very seriously in our program. We not only discuss with youth their rights to accessing confidential healthcare services for their sexual and reproductive healthcare needs, but we also begin our conversations about their psychosocial histories and sensitive aspects of their healthcare and lives with a conversation about the limits of confidentiality, that everything is between us, not unless their lives might be in danger, not unless somebody else's lives might be in danger, or if they might unfortunately be experiencing physical, verbal, or sexual abuse. We also display materials such as this poster from the Adolescent Health Work Group that very explicitly communicates to our adolescent their rights to confidential healthcare and our commitment to protecting this. We truly want to engage and empower youth in their care, and we hand out materials such as this document, also taken from the Adolescent Health Work Group, about their rights and responsibilities when accessing our behavioral health services. On measures of visibility, our services are recognizable, convenient, and does not require complex planning by youth such as JP to access. This here is one of our 3 mobile medical units in our program, and you will see that we clearly have an image of an adolescent in our mobile unit wrapping, which makes us readily identifiable as a youth-serving program. This here is our other mobile medical unit, which also prominently displays images of youth. Additionally, JP was able to see us on a Thursday evening after school, when most pediatricians' offices would already have been closed, because we know about the barriers youth face in accessing health services during usual office hours. These are hours when youth would otherwise be expected to be elsewhere. And that can be very difficult for youth, especially when they're trying to access services without their parents. Our services are also accessible in a wide range of healthcare settings, with this particular clinic that JP saw us in at our partner location with 1 in 10. 1 in 10 is a Phoenix-based nonprofit that serves LGBT youth between the ages of 14 to 24 by providing empowering social service programs that promote self-expression, self-acceptance, leadership development, as well as healthy lifestyle choices. They run a weekly support group for LGBT youth on Thursday evenings, and we chose to go there at the same time, knowing that this was a place where young people would congregate. Information about our programs, our services, or the sites that we go to, as well as our schedules, are also readily accessible to youth online, on our website, which we know is really, really important when you're trying to engage youth in this digital world. In measures of flexibility, our services, clinicians, and delivery sites cater to the developmental, cultural, ethnic, and social diversity among adolescents. We worked very hard in the design of our spaces to make sure that they were friendly and welcoming to adolescents. This here is the front of our mobile medical unit cab, as well as one of our exam rooms in the mobile unit that JP came to see us in. This image is another one that looks down at the length of our mobile medical unit, and this is a space where you won't find Barbies or Buzz Lightyears. We also care for an incredibly diverse group of young people, especially from the standpoint of race, ethnicity, gender identity, sexual orientation, and sexual expression. When youth come to us with concerns about their sexual and reproductive health, we meet them without judgment and make no assumptions regarding their gender identity, sexual orientation, or sexual behaviors. JP would have seen this sign indicating that our clinic was a safe space when he walked into our mobile medical unit. In addition to our 3 mobile medical units, our program also provides clinical services out of 3 licensed fixed-site clinics. In these clinics, you will see a large framed photo images of youth on our walls, and these are youth who are actually served by our program. In these images, you will see the tremendous diversity of the youth we serve. On measures of coordination, our program offers a comprehensive array of services, including access to mental health counseling and assistance with referrals for services such as optometry and dental care. When JP came to see us in our program, he completed a routine screening tool for depression called the PHQ-9. While his screen was negative, had that been positive, we would have encouraged him to engage his parent in his care and helped him access mental health counseling services. Lastly, in terms of quality, this case underscores a critical gap in the delivery of sexual and reproductive health services, especially for lesbian, gay, bisexual, transgender, and questioning youth. Closely following the Centers for Disease Control's guidelines for screening for sexually transmitted infections in groups such as males who have sex with males is critically important. In this particular study, for example, which was conducted in 5 large urban cities in the United States, they found a rather significant prevalence of chlamydia and gonorrhea infections in extraurethral, extragenital locations. In fact, if one was to only rely on urethral screening for infections, they would have missed about a third of all gonococcal and chlamydial infections among the MSM youth that they served. In our program, we perform universal screening for HIV infections in all our youth beginning the age of 13. This closely follows guidelines from the Centers for Disease Control for universal screening for HIV infections in all individuals between the ages of 13 to 64. We know that young people bear a disproportionate burden when it comes to new HIV infections. In fact, in 2015, almost 1 in 4 new HIV infections were among youth between the ages of 13 to 24. Despite this, the rates of HIV testing in the population are very, very low. In one study, only 10% of our high school students report ever having been tested for HIV. Well, thank you very much for joining us in this session, taking a look at the special needs of adolescents. It's our hope that you have found the session to be valuable and informative.